So I'm going to start with one case presentation. This was actually my very first case as an attending. 76-year-old man with CAD, had prior PCI, end-stage renal disease, on dialysis, COPD, and obesity. He was found to have osteomyelitis of the right lower extremity, fifth digit, and underwent amputation with one of our podiatrists. He then subsequently obtained ABI, which showed 0.5 on the right lower extremity. Here are his angiograms when I took him to the lab. The patient actually did not remember that he had an iliac stent, but here's an iliac stent that was previously placed. You can appreciate the tortuosity of the common iliac as well as the internal iliac here. The stent here, as you can see, is a little bit undersized proximally, and it almost looks like it's a little bit wrangled. So that's an important thing to point out here because it will ultimately affect our decision for how to treat. The iliac itself is a little bit aneurysmal proximally, otherwise is relatively free of disease. There's a mild ISR within the stent itself. The common femoral is relatively free of disease, as is the SFA. When we go below the knee, you can appreciate that the AT is completely occluded proximally. Distally, there is reconstitution in the DP. So what would be your approach given the tortuosity of the iliacs as well as the undersized stent? Should it be contralateral access? Should I get antegrade access? And then should I go with retrograde up front or just try antegrade first, dissection and reentry? Ultimately, I actually decided to go with an antegrade access just because of the difficulty crossing that iliac. When I did put in a catheter past the stent, importantly, there was no notable gradient across the stent, so it did not require treatment. So I also decided to merge antegrade and retrograde access techniques and then dissection and reentry. So here I have a Glygold from the antegrade side and obtained retrograde access into the DP, placed the Glygold from a retrograde standpoint as well. The two met in the proximal AT, and then ultimately I was able to feed the Glygold into a antegrade CXI. I only saved a frame that it worked in, so. So I ballooned this with a compliant 2.5 balloon, and you can see there's still significant residual stenosis. So I further dilated using a chocolate 3.0. And this was the completion result with intact flow to the AT. His ABI, I don't have the actual digital ABI, but it improved from 0.5 to 0.8. I'm also trying to actually work with our vascular lab because, as you know, a TBI is also very important in this. So the institution I started at, we were working on getting a TBI. So things to expect in your first month as an attending. Start building a referral base, so meeting all the podiatrists in your area, meeting your vascular surgeons, as you know, they're going to be great collaborators in your work. Knowing all of your wound specialists, because after you do your intervention, that's not where the care for the patient ends. It's the continuing wound management of these patients. Knowing your cardiologist and your PCP is also very important, as these become a large referral base for you. And obviously be humble. You're the new guy or the new gal in town. You're here to help and learn from your senior partners. Don't be, pompous or cocky. Always be available. Make sure that your cell phone is readily available to everyone, and make sure that you communicate with your referring physicians. In the last peripheral talk, we also discussed a little bit about billing, and that's something that we never learn in medical school and very seldomly in training as well. So I encourage you, as you kind of go through your fellowship, understand more and more about how to bill and, exactly in peripheral procedures particularly, because there's actually a lot to learn from that aspect. So also, more importantly, know your limitations. Things to avoid in your first month as an attending would probably be wounds like this or like this. However, some things were unavoidable. This is my second case as an attending. This was a 75-year-old man with ischemic cardiomyopathy. He has known CTO of the RCA and circumflex with an EF of 15 to 20%. He had a history of Guillain-Barré, had plasmapheresis in 2014 with essentially recovered function. He was actually living on his own. he had been telling his family that he had sprained his Achilles tendon for the past 4 weeks. And finally, the family noticed that his house was starting to smell a little bit, and they brought him into the hospital. As it turns out, he has bilateral heel wounds as well as bilateral exposed Achilles tendons. So his ABI, as you can see here, on the right was 0.31, and on the left was 0.36. Given the ABI findings, concern was for bilateral SFA occlusion, and a bilateral AKA was offered by the vascular surgeon. When I first saw him, his right Achilles tendon was still kind of white and pearly, still actually looked healthy despite the loss of soft tissue around it. His left Achilles tendon actually looked worse than this. It was completely black, and so was the heel. So when I talked with my podiatrist, the thought was maybe what we can do is try to save his right leg, given that it was still the tendon still looked healthy. I actually had intended to bring him into the lab that same day. Unfortunately, he has some anemia and some hypotension necessitating blood transfusion. So his procedure was delayed for a couple of days as we kind of worked up the anemia. So by the time that I brought him to the lab, his right Achilles actually had already progressed. What you can see here is that it's becoming black and yellow colored. So I took my initial angiogram up and over. There's, as you can see here, common femoral disease that's calcified. The SFA is occluded. There's osteoprofunda disease. Completely occluded reconstitution below the knee in the P3 segment. There's an AT and essentially no flow actually to the posterior side of the leg at all. So I actually started initially with an antegrade approach with a stiff angle glide wire and NaviCross. That did not actually penetrate the proximal cap at all. I attempted retrograde access into the DP, however, there was a lesion in the DP which prohibited that. So I ended up going retrograde in the proximal AT. This is the micro access wire, which was then subsequently exchanged for a glide gold with CXI support. I did have to modify a JR4 proximally to really engage the cap and advance the stiff angle glide wire. And ultimately, I was able to meet the two and externalize the retrograde wire. So I performed these.
You said you graduated 2 weeks ago?
Uh-huh.
Yeah.
So I performed DCB of the CFA and the SFA, ended up placing a supera behind the knee because there was residual dissection and disease in the distal SFA and in the popliteal artery. Below the knee, I actually tried to go through the peroneal artery. It was really calcified. I couldn't push any equipment down at all. And I actually tried to cross the pedal arch as well. I suspect he probably had an incomplete arch. So these are my final pictures. So this is the common femoral SFA, popliteal, the superas are from here to here, and the AT, and you can see the disease that was in the DP. So the goal in him, so he's actually going to end up getting a left lower extremity, so the contralateral leg is going to get an AKA. And we're going to do watchful waiting on the right lower extremity. Depending on how the tissue responds now that the inflow is open, and there's actually a trickle of flow through the peroneal now that I've poked it a bunch, he may ultimately still require BKA, but at least he would have an AKA and BKA as opposed to bilateral AKs.
Thank you so much. Stay here.